Okay, everyone, good morning, good afternoon, depending on where you are right now. Thank you for attending today and welcome to this edition of the College of Earth and Mineral Sciences 125th Anniversary Educational Series. My name is John Leese, and I'll be moderating the presentation today. I'm a 1976 graduate of the college with a degree in Earth Sciences, and I currently serve as a board member on the Graduate of Earth and Mineral Sciences, or GEMS board. And it's the GEMS board that sponsors this series. I'd be remiss if I didn't also acknowledge the strong support that's provided by the college's development and alumni relations and marketing and communication staff in assisting and putting on this series. So thank you for that. These presentations highlight the college's research in short, interactive webinars, and they're intended to engage your curiosity and introduce you to our world-class faculty, alumni, our academic programs, and research activities. And this is the sixth presentation in the series, which began last December. Our presenter today is Dr. Brian King, and his topic is Infectious Addictions, Geographies of Colliding Epidemics. Dr. King is a professor and head of the Department of Geography at Penn State. He has affiliations across the university, serving as a faculty research associate with the Population Research Institute, research affiliate with the Earth and Environmental Systems Institute, and faculty affiliate with the School of International Affairs and Consortium to Combat Substance Abuse. Ryan is also an honorary research associate with the African Climate and Development Initiative at the University of Cape Town and was selected as a National Academy of Sciences Kavli Fellow in 2017. Brian's research activities concentrate on livelihoods, conservation and development, environmental change, and human health. His book, States of Disease, Political Environments, and Human Health, received the Julian Mingy Distinguished Book Award from the American Association of Geographers. More recently, he is leading a multi-university team that is examining how COVID-19 is transforming the US opioid epidemic. There will be an opportunity to ask Brian questions following his presentation. You can submit your questions by clicking on the Q&A icon that's at the top of your Zoom screen and typing in your question. We'll gather those questions up and sort through them and then present them to Brian at the end of his presentation. We very much appreciate Brian's participation in the virtual education series. So with that, I'll now turn it over to you, Brian, to begin your talk.
Great, thank you. So the customary, I'm going to share my screen and I hope you can see it. Let me do this quickly. Okay. Okay, well, thanks so much first for everyone involved with organizing this series and for all the support that I've been given in terms of getting this presentation together. And also very much appreciate the invitation to be with you today. It's very flattering actually to be asked. And I'm very pleased to present a short 20-25 minute presentation on some existing research that John alluded to in the introduction. And so thank you very much for being here for this. Just by way of a bit of a background, maybe a little bit on myself, but also intending to give a little bit of recognition of the discipline of geography with regards to some of the themes I'll be talking about here today. I have a longstanding interest in health, infectious disease, how those interlink with processes of socioeconomic kind of inequality, race, and more recently addiction. And I'm going to talk entirely today on the topic of COVID and opioids, but I did want to share 3 images on the left of the screen here that come from a longstanding research project with support from the National Science Foundation, looking at the management of HIV within rural South Africa. I've worked in Southern Africa for over 20 years, and that project really built upon my dissertation work, trying to evaluate kind of post-apartheid change within South Africa. And I think many of you know that South Africa has been significantly impacted by the HIV/AIDS epidemic and actually has estimated to have the most people living with HIV of any country in the world. And so those images come from some of the communities in which I've lived for some time. And the one in the middle of the slide points to one of the key findings from that research, which is that as people have gotten greater access to antiretroviral therapy, other types of resource needs are increasingly being recognized. And first and foremost is food. And so food security for people who are living with HIV is critically important because these drugs are difficult to adhere to if you don't have consistent food. We also need to think about nutrition security in terms of what that means for keeping a healthy immune system. Prior to the pandemic, I was beginning to grow a project in the United States, specifically within rural Appalachia, looking at the impacts of the US opioid epidemic. And as the next slide will allude to, trying to leverage some existing subfields within the discipline of geography to evaluate opioid use and misuse. What we found with COVID-19 was that my team and I had to make some adjustments in terms of our focus. And I think the rest of my presentation will make it pretty clear why we've really made COVID-19 central to the framing of the ways the US opioid epidemic is currently manifesting itself. Upper right from the press, from the New York Times, there's been reporting on upticks in addictive patterns or overdoses. And I'll come back to that image on the bottom right, which is from a current research project that our team is working on, looking specifically in the state of Pennsylvania on opioid misuse. So geography is a discipline, and I find myself oftentimes being interviewed or being asked what geography brings to bear in terms of questions of infectious disease and human health, and quite a lot actually. There are 2 subfields of geography I think that have made the most contributions to some of these topical domains: medical geography and health geography specifically. There's some differences to them. I'm not going to get into that unless people have questions. I'm happy to take them, but I think broadly defined, these subfields have made contributions to human health by addressing spatial patterns of disease exposure, locating healthcare services, and also with an eye towards recognizing inequities in terms of the provision and access to healthcare within the US and other contexts, and also the role of place-specific processes. And what I mean by that are locally kind of contextual or contingent factors that contribute to particular health outcomes and can also contribute to uneven outcomes across space. And I think in my rest of my talk, I'll hopefully give you a sense of that. Human geography more broadly and human environment geography have also engaged with questions of human health, focusing on the human body and also the internal body, uncertainty around healthcare and around infectious disease spread, for example, and also thinking about health and environment interactions. What I would argue, and this comes from a paper that my co-author, Dr. Andrew Rishworth, and I are just published in Progress in Human Geography, is we argue that geography, as with other academic disciplines, sometimes focuses on a single disease pattern. And so like malaria, right, or West Nile virus, and sometimes do not associate those with co-occurring other types of health challenges or even other types of infectious diseases. Outside of geography, the concept of syndemics gets used in this regard to think about kind of, again, overlapping or co-occurrent disease challenges. And so in that paper, Andrea and I are arguing that geography has something to say to that. And so I think this hopefully will become clear in the remainder of my presentation. So what I want to do is let me just give a little bit of an overview of the US opioid epidemic. I think this has gotten quite a lot of attention. And so many or all of you are probably familiar with just the significance of this epidemic. And this slide comes from Health and Human Services prior to COVID. And so it's giving some numbers that just demonstrate nationally how significant the US opioid epidemic has been in terms of loss of life, in terms of use of other types of opioids beyond prescription drugs. Just broad swaths of the population, unfortunately, has really wrestled with opioids. And this was prior to the COVID-19 pandemic. It's become fairly common to talk about the US opioid epidemic as not one big thing, but actually a series of stages or waves that have unfolded over time. And those waves have also begun to bring in different populations, different areas. So I think there's still a little bit of in the cultural imagination that the US opioid epidemic is white, rural, primarily men. And there is evidence, of the epidemic that there's been disproportionate impacts among that segment of the population. However, when we look at the US opioid epidemic over a longer time period, we have to recognize there's a little more nuance in terms of both the location and the populations who have been impacted or are being impacted by opioid use and misuse. The first wave, if you can see my cursor, really began kind of prior to 1999, but this is where we started to see the real uptick in, at that time, commonly prescribed opioids. And I think that many of us are familiar with this idea of the pill mills and places where doctors were basically taking advantage of prescriptions for the purposes of profiting. There was also the industry spent quite some time asserting that prescribed opioids are not addictive, and of course that's not the case. But so it's taken time in lawsuits to begin to try to remedy the damage from that. And so we see the initial wave of opioids was really concentrated primarily on these prescribed opioids. We started to see a plateauing of that in the 2000s. There started to be more surveillance on the prescription of these drugs, more recording. It was a lot more challenging to just kind of illegally or too broadly prescribe these kind of drugs. And so this second wave in the opioid epidemic is where we began to see an uptick in heroin. And sometimes these, I don't mean to suggest these would be used mutually exclusively. You could have people wrestling and using a variety of opioids. But as we saw a pullback on prescription opioids and also potentially kind of a desire to get something stronger, heroin began to really drive the US opioid epidemic. More recently, over the last, kind of 7 to 8 years, we've seen a real spike in what's being called a third wave in these synthetic opioids. And these are like fentanyl. We find carfentanil is also being used now in the state of Pennsylvania. These are more dangerous, they're more addictive. And so this is a real concern in terms of, and you can see this in terms of deaths associated with opioid overdoses. So these are really now driving a lot of the use and subsequent overdoses. What I want to do in my remaining 15 minutes or so is ask a bit of a question. I don't have a complete answer for this, but what I do want to do is update us to the current moment. And so this image really ends at 2018. And so the rest of my talk, I'm going to concentrate really over the last 3 years. And our team is in some ways asking the question of whether we're seeing a potential fourth wave here. And what that fourth wave may be characterized is further increases in overdoses to opioids. And also, is the epidemic changing in terms of the location, in terms of the members of the population who are now being most impacted by opioid misuse? And so I'm going to focus this on the very current time period. And the subtext here is a broader question that I think we're really intent on trying to engage with. So I'm going to keep this, relatively contained. I'm just going to present 2 sets of findings. And the 2 sets of findings come from 2 different time periods. I'm going to call the first time period immediate responses to COVID-19. The second time period is more longer term. And so the immediate response, I'm going to share a kind of a completed study that we published. And then the longer term responses is our team is working very actively now to look at kind of the longer patterns of opioid misuse and overdoses during the COVID-19 pandemic. So when I talk about immediate responses today, I'm going to talk about mandated stay-at-home orders. And so let us think back, to March 2020, when the severity of the pandemic was really becoming pretty clear. And you had, dozens of states respond with a variety of public health measures to try to mitigate the spread of infection. We think about social distancing, mandated masks, but then a number of states mandated stay-at-home orders for discrete periods of time with the intention of really trying to bend the curve, if you will, in terms of transmission rates within their states. And so you see California was the first to do so, but then there was really a wave of other states. And it was announced in March by Governor Wolf that the state of Pennsylvania would also have a mandated stay-at-home order that would begin on April 1 of 2020. The intention was to begin to release it at maybe a month later or a little bit later into the summer, based upon what the data were showing of transmission. So in terms of, this is kind of my only kind of like method slide, but I want to be clear about how we're doing these analyses. And so the rest of my talk is concentrating on the state of Pennsylvania. We are also working in West Virginia and Kentucky. And so, but for my presentation today, I'm concentrating on Pennsylvania. And another reason for that is Pennsylvania is fairly unique in having a database that is updated very regularly on overdoses. The other two states I mentioned don't have anything like this. And so as we do this kind of analysis in other parts of Appalachia, we're going to have to work with different types of data sets. And so Pennsylvania has what's called an Overdose Information Network, ODIN database. This is provided by Pennsylvania State Police. It also has data from first responders, and it's basically just updated daily on the numbers of overdoses and then attributed to specific opioids within the state. And so this is a pretty rich database that's allowing us to do some work that we couldn't do if we were concentrating in some of the other states. So for the immediate, so I mentioned I was going to talk about two projects. So the first project is these immediate impacts. And so for this analysis, what we did, and this was specifically myself, Dr. Andrea Rishworth, and Ruchi Patel, with assistance from Dr. Louisa Holmes and also some folks from the Population Research Institute, we compared April 1st through July 2020, so those 4 months immediately following the mandated stay-at-home order in the state of Pennsylvania. We compared those 4 months to the preceding 4 months, so specifically December 2019 to March 2020. But because the ODIN database also went further back, we also compared April to July of 2020 with the previous 15 months. And so that's how those, those are spelled out here. The idea here was essentially to ask the question, what happened with overdoses beginning on April 1 during the mandated stay-at-home order, at least during some of the time period of that stay-at-home order. I'm going to report on that in just a minute, but I also wanted to mention that we also are looking at population and spatial patterns more longer term. So I'm going to share with you some preliminary analyses that are doing some comparisons from 2018 and 2020, and we're continuing into the future. So again, here we're trying to get a little bit more of a longer term perspective. Finally, we're not just doing quantitative analysis, we're also integrating qualitative interviewing. And so I'm going to show you some data findings. I'm going to show you one map of county level overdose change, but the qualitative interviews are allowing us to really help explain those patterns. So when I mentioned before about place specific processes, these interviews are incredibly rich and valuable in trying to understand some of the drivers of change during this particular time period. So in terms of the first study, so again, this is looking at the immediate rates of overdoses in the state of Pennsylvania from opioids during the 4 months following the mandated stay-at-home order in April 1, 2020. And what we found was that there were statistically significant spikes in overdoses. Those increases in overdoses occurred for both men and women, for both white and Black groups in the state of Pennsylvania. And also we noticed statistically significant increases between ages 30 and 39 and 40 to 49. And so I had another table that I've shared in other presentations that's just very kind of heavy. And so I'm not sharing that with you today, but it just really pops. And so, and I'll show you a couple of figures which demonstrate that. We also found significant increases in specific overdoses attributed to heroin, fentanyl analogs, and a little bit of pharmaceutical opioids, but also carfentanil. And so there's a class of drugs that are being attributed to those overdoses that are also showing a spike. And so we reported on that in the Journal of Drug Issues paper that was published this year. It's at the top image. We also, again, this is Dr. Andrew Rishworth, Ruchi Patel, and myself. We also published a piece in The Conversation, which is a more of a public-facing outlet for scientists to present their research to other sources, including the media. And so this was our attempt to get this information out more widely. Show you two figures that really just kind of demonstrate what we're talking about here. And so you can see this. This is the April to July time period in which we were doing the comparisons. And so you can see this is the statistically significant increase during that time period, where you just see a real I'm reticent to use the term spike, but I'll just say a statistically significant increase in overdoses. And you also see that in terms of naloxone, which is administered to assist with survival of an overdose. It's highly effective. And in fact, the overwhelming majority of overdoses in the state of Pennsylvania do not result in death. The reason why the naloxone curve is higher is because you would have sometimes more than one distribution for someone who's overdosing. And then this is the drugs themselves. And so here you can see the heroin. This is this kind of initial real kind of spike during this time period, a leveling off, and then a drop, a little bit of movement as well with fentanyl and some of the other drugs. And so those visually represent that kind of pretty rapid change in spring 2020. Now, again, the interviews that we've been doing, we have 10 public health partners across the 3 states, and I believe a couple of them are attending this presentation. So it's just thank you for being here. And so we've begun interviewing within that group, and then others who are working within Appalachia, asking questions to try to understand, some of these patterns. And so, for example, one addiction treatment counselor explained to us that, one of the triggers is mental health. Mental health is the biggest, they suggested, in contributing towards relapsing. In the recovery world, they shared people with significant clean time, like 25 years clean off of all substances, people that I looked up to, in essence, relapsed. And he said, we're gone. Another, and we've heard this across 3 of the states, is that the extra finances that came from the CARES Act. So remember, there was a first stimulus package that was intended to kind of offset some of the severe economic impacts of COVID-19. This resulted in people getting checks. And we have heard from providers across all 3 states that might have contributed to some relapsing, unfortunately. As one public health provider said, maybe it's been helpful in terms of people being able to stay in their homes, but the extra money is definitely, from what patients have told me, caused them to relapse or use other substances. We've also, I think this is primarily because of the conversation piece that I mentioned to before, this has resulted in this research getting some public media attention. And so we were interviewed on Smart Talk, which is the Harrisburg public radio station. We're able to talk about some of our findings. I also just last month was interviewed by a Danish newspaper called Weekend Division, and they were interested in some of these general patterns. This is all in Danish, so the only thing that I can really pick out is my name there, Brian King. And then finally, I like sharing this interview that I did with a local CBS affiliate where I was referenced as a professor of geology. And so this is a longstanding challenge for us that we're very mindful of in geography. The other 2 collaborators were really kind of upset about this. I kind of chuckled because I knew I'd get to share it in talks. And so again, really reaffirming what geography is as a discipline and what it can bring. To then kind of begin to wind down, I just want to share that second project, and this is ongoing, and this is involving Dr. Andrew Rishworth, Ruchi Patel, but also my colleague, Dr. Louisa Holmes, who I also believe is attending. And Louisa, thanks for being here. And so this project, we're trying to look at longer term patterns. And so this figure and the subsequent map I'm going to share with you come from Dr. Holmes, where using the same database, but thinking about kind of multi-year potential changes. What these V's indicate is that from 2018 to 2019, there was actually a statistically significant decrease in opioid overdose overdoses and deaths during that time period. But then subsequently in 2019 to 2020, the V went in the other direction. And so we saw statistically significant increases in overdoses and mortality from 2019 to 2020. As one of our partner explained to us, in essence, we were making progress until COVID-19 hit. We're also seeing geographic variation. So this is overdoses from 2019 to 2020. So it's comparing those 2 years, again, using that same database, but it's at the county level. So these data are also locationally based. And so that allows us to do some geographic or spatial analyses. So all of the counties in Pennsylvania you see that have kind of a reddish color showed a statistically significant increase in 2020 compared to 2019. Conversely, there's a small number, I think just 2, 4, 5 counties that are some shade of blue in which there was an overdose decrease during that same time period. So this tells us some things. This tells us that there are spatial variations. It tells us that perhaps some of the dynamics going on within local contexts make a real difference in terms of how people were contending with opioids and overdoses during 2020. But there's also a geography here that we don't have a full sense of, and we need to continue to investigate. So for example, if we were to overlay infrastructure onto this map, would that suggest that there's clear pathways where some drugs are entering some of these counties? Some of our interviews suggest that's the case, that there might be proximity to some other counties or specific highways that make it easier for some of these opioids to get into these rural counties and urban settings as well. So when asking a public health provider about like state level variations, so we were kind of probing on that, this provider agreed with that and said, well, in Western Pennsylvania, where I'm from, there's a lot of variation between counties. So you can drive 20 minutes across the line and it's almost like it's a different state. And so they were agreeing. I said, it's absolutely true. I think the rates of use are similar, but you see some sort of different sort of associated factors with substance use in these counties. We're asking specifically about Fayette and Greene County. Like in Fayette County, there's a lot of violence associated with drug use. And in Greene County, there really isn't much, It's more of a rural county, but there's more land. So there's definitely some differences, but I think the use rates are pretty similar, this provider shared. So I want to make sure I wind down so there's time for questions. And so I just want to conclude with this slide. This is future directions for geography, but I also think it's future directions for research on these patterns. Simply put, the COVID-19 pandemic has collided with the opioid epidemic. It's had significant impacts in terms of accelerating or intensifying opioid use and misuse, and it's clearly kind of correlating with upticks in overdoses within the state of Pennsylvania and elsewhere. So in essence, COVID-19 is intensifying, and I say potentially transforming the US opioid epidemic. I'm not yet confident to say that we have, going back to that previous figure, entered a fully discrete fourth wave, but I did want to share that with you so you got a sense of our thinking in terms of how we're approaching this. But a lot of our attention moving forward is questioning the degree with which the US opioid epidemic has fundamentally changed because of the COVID-19 pandemic. I would suggest this research demonstrates that opioid use should be addressed alongside efforts to mitigate and manage COVID-19 infection. So this is the theoretical framing at the beginning where I said we need to think about the co-occurrence of multiple disease challenges or health challenges. And specifically, future research on opioid use and misuse is needed to understand differential impacts for people and the new challenges for addiction treatment. If I had more time, I'd talk about telehealth. That is something that we're spending a good amount of time with in our interviews talking about. So the state of Pennsylvania shifted to providing greater access to addiction treatment services using telehealth or telemedicine. And so I think that there's a potential really fascinating set of questions about what that means for people pursuing care, providing care, and the geographies of access to healthcare in this kind of new normal. So I've mentioned a number of these names before, but in my talk, but I wanted to say them again. This is a team project. I get the pleasure of coming and presenting with you all, but this would not be possible without Dr. Louisa Holmes, Dr. Andrew Wishworth, and Ruchi Patel, who are core members of our Penn State team. Don Miller and Ji Chen at the Population Research Institute helped with some initial analyses of overdoses. And then I did want to acknowledge our research partners in the states of Pennsylvania, West Virginia, and Kentucky, specifically in Pennsylvania, because that's where the focus of my talk was today. I wanted to acknowledge Kelly McEvitt, who's the Executive Vice President and CEO of Southwestern Pennsylvania Human Services, Janet Kyle, who's the Executive Director of Fayette County Drug and Alcohol Commission, and then finally John Fox, who's the Greene County Director of Drug and Alcohol Programs. They've all been incredibly supportive, and I'm very much looking forward to continuing to collaborate with them as we move forward with this research. I told John I'd just share these last two slides and then we can open it up for questions. And so thanking you all who are present for this, for being here, but also potentially taking advantage of some of the ways to stay connected with the college. And there's some links here, and folks in the College of EMS and GEMS can share these with you if you don't have them already. And then finally, feedback on future presentations and topics are always welcome. And so there's an email address there, gems@ems.psu.edu. So do feel free to share ideas of topics that you might be interested in. And thank you very much for being here.
Thanks very much, Brian. A great presentation and very interesting. As we've talked during the development of this presentation with you, it's pretty amazing that the application of geography to an issue like this related to health. It's a real eye-opener, and I think it's a great way to demonstrate the breadth of not only geography but your department and the work at Penn State in a very important crisis that we're having right now. We have several questions for you if you're ready to go.
Sure.
First one is, what is the per capita use of opioids in Pennsylvania versus the nation? How does Pennsylvania rank in that statistic?
Yeah, I can't answer that fully. It's a really important question. I think that historically, Pennsylvania has, and this is prior to 2020. So prior to the COVID pandemic, Pennsylvania was one of the top states in terms of rates of overdose. I don't know if some of those, and when we talk about rates, we are talking about adjusting for population. And so there is still a reason why when we think about opioid in particular, we tend to think about Appalachia, of which part of Pennsylvania is contained within. And so that having been said, in that third wave I alluded to, I think the city of Baltimore was really going up in terms of use of opioids or opioid misuse from fentanyl in particular. So it's a little bit of a moving target, but I think it's very safe to say that this is a long-standing challenge for the Commonwealth. I think this is one of the reasons why the provost of Penn State initiated a consortium that has now been renamed. So it's focusing on substance use and addiction is the name of the consortium. I'm part of it, as well as some of my other faculty are part of it. And so I think that was a recognition on the part of the university that this is a significant public health challenge in our backyard, and particularly with the breadth of our university across 20 plus counties, campuses, but across multiple regions, we almost have an obligation to really focus on it. And so I'd be happy to follow up and give you very specific data, because some of those would be available. But what I can comfortable saying based upon the data that we've been working with is that Pennsylvania continues to be quite high in terms of use patterns for opioids. Okay.
The next question, there was a peak in opioid use in the mid 2019 that was as large as the peak in 2020 when the governor issued the stay-at-home order. It's not clear that the order was the cause of the increase. Any comments on that?
Yeah, really great points. In terms of the latter, I want to be really clear that when Andrea and Ruchi and I published the paper in the Journal of Drug Issues, and when we published in the Conversation, and as we've been interviewed, we've taken pains to be really clear that our intention is not to critique the stay-at-home order. And so that is not what we're intending to do. I fully remember what it was like that week in March, when we started to really realize how severe this pandemic could become. And so the governor's response, I know I speak for all three of us, we applaud it, we support it. That was a necessary set of, in my view, set of actions to try to mitigate the spread of COVID. The issue here is that it also raised situations that made it challenging for people who were either in active recovery or were, kind of struggling with addiction. I think I want to catch another question, but I know another GEMS board member was curious about other drugs like alcohol. And I think we've clearly seen evidence that there's been upticks in alcohol sales during COVID-19. And I think this is driven to just the difficulty for people to be socially isolated, the challenges of economic challenges. So a number of lots of people who are kind of on the edge of economic precarity, maybe losing employment, housing becomes threatened. And that can be kind of a trigger for opioid use and addictive patterns. In a number of our interviews with public health providers, we have really tried to engage with this question of telehealth, because and I think what we hear consistent, what I mean by this is if you're seeking addiction treatment services, you can now access some of those services over the phone, by Zoom, where previously you would have had to go in and be seen by a provider, even for just like 20 or 30 seconds, but the provider was expected to have you come to site and pursue care. Because of COVID, that could not continue, or at least the belief was that that could not continue, at least in the short term. And so there was, I think it's safe to say, a fairly aggressive loosening of provision of some of these services, using the phone, using Zoom. And I think it's safe to say that to the person that we've interviewed, we're hearing that it presents real opportunities to expand access for people. So for example, we hear stories from some of the addiction treatment specialists in Western Pennsylvania that now somebody doesn't have to take 3 hours off of work, drive into Pittsburgh, get care, and then drive home. They can actually just, on their lunch break, pursue care. And so there's a real potential that there's increased access to some of these types of services through telehealth and telemedicine. That being said, I think we all know that there are population and geographic variations in terms of access to reliable internet, reliable sources of technology. And so access is probably also constrained for some populations. I can speak to that as a professor at Penn State, because that semester, spring semester 2020, we were very conscious of the fact that there were students who were going into McDonald's so they could have internet access to access their classes. So we just heard stories of just challenges that our students had in terms of being able to maintain their coursework during that time period. I would suspect that there's probably some similar challenges for people elsewhere in the Commonwealth in terms of accessing certain types of telemedicine. So I think in terms of that, I think it has opportunities, but there's also some challenges that we would need to address if some version of it were to maintain. The beginning part of the question was 2019, and then 18, and then 2020. I think what we're prior to 2018, you were still seeing fairly high levels. And what was really, I think, happening was right before COVID, there was the curve was bending. And my sense from Kelly and others that I alluded to in our public health working with us is that we were making progress, and that there was greater provision of some preventative care, needle exchange and other types of testing for people who would be coming into clinics for certain types of services, and provision of naloxone, provision of other types of response for first responders and others. And so I think we really were beginning to see some progress and some light. And then unfortunately, COVID has just really intensified it. And so the long answer, it's a really important set of questions you asked. I did want to begin by just qualifying that our intention here is not to say this become a talking point that there should not have been a mandated stay-at-home order. Instead, what it suggests to me is that when we think about public health does this routinely. I don't know that academic scholarship does it as effectively as the dangers of thinking about a single health challenge in isolation. And I'm culpable of this as well with my South Africa project. My focus has been on HIV, but at the same time, there's significant rates of tuberculosis, other kinds of health challenges in the communities in which I've worked. And so I think this kind of more kind of syndemic or multi-disease or co-occurring disease perspectives, very common, within public health. So I'm not critiquing that sector. I'm just suggesting in terms of scholarship, the potential value of really thinking about the interactions of these and how they can intensify each other. Thank you for those questions.
Okay, a follow-up to that discussion just now. What are the key takeaways that you feel policymakers and healthcare officials should consider going forward? For example, do you envision that this work could evolve into a model that could be used in the future to allow agencies and healthcare providers and decision makers to more fully predict and better plan for a major societal disruption like a pandemic?
Yeah, really great questions. In terms of thinking about some of the policy implications of this, one of the main ones that, and this has also been driving our interviews, is thinking about telehealth. And so there is, I think, a little bit of an open question on whether states of Pennsylvania will begin to go back to the modalities of care that existed prior to COVID, or whether COVID has opened up some greater flexibility in terms of providing treatment for addiction treatment services. And so I think based upon, again, some of this is still preliminary, but certainly what I'm hearing from the experts that I spend time talking with is that there's probably a real argument for keeping some flexibility in terms of provision of certain types of care for addiction treatment. And so this is probably analogous to all kinds of sectors in society where I think, we're thinking all kinds of employment sectors, all kinds of ways that we engage in work and caregiving. I think that there's some open questions about whether we're going to be seeing some revised modalities because of COVID. It's just basically exposed maybe some of the limitations that existed prior to the pandemic. We're certainly having those discussions. I was in a discussion this morning within my college about what this might look like in terms of academic departments and workplaces at Penn State. And so I think in terms of care provision, it's exactly the same. And it seems to me that there's a real case to be made to kind of keeping some of those types of care available. In terms of the question about a framework, we're definitely not there yet, but I think that it's very realistic to think if we have a similar kind of highly infectious respiratory disease, which, a lot of public health experts suggest is likely in the future, that we would anticipate similar kinds of disruptions for people who are dealing with addiction or are seeking out certain types of care. And so I think, maybe not a framework, but certainly lessons can be learned from this about what ways to mitigate the spread of infectious disease while also mitigating the potentially negative consequences for people who have other types of care needs. And so I think that as we kind of look at more of the longer term, as we kind of maybe get into 2021 and think about those patterns, there's some general lessons that we can learn from that. And that's certainly we would be continuing to communicate within some of these non-academic outlets. I just think it's too urgent and pressing for us not to be speaking in a variety of different ways.
Okay, thank you. We have a couple of questions that I think are related more into the data set that you discussed earlier. You reported a significant decrease between 2018 and 2019 in opioid usage and deaths. This occurred while unemployment was decreasing and one would expect more access to cash. This doesn't seem to square with your suggestion that the available cash resulted from the stimulus funds caused an increase. In the first instance, there was a decrease, and in the second, an increase. And then I guess a related question is the opioids that were cited in the study, were they all available as prescription basis, or some available through illicit manufacture and marketing?
Yeah, it's a really good question. It's difficult. I appreciate that. The comment about the CARES Act stimulus spending potentially contributing to upticks in overdoses, that's coming entirely out of the qualitative interviews we've done. We haven't probed it. And so there's different strategies you can use as an interviewer. You can ask that question directly. We've deliberately been a little more open to see if informants would raise that themselves. And we have heard that across all three of the states. Now, again, it's primarily anecdotal, but it's based on people who are providing these services day to day. Whether that's a large enough number, so I use the term anecdotal deliberately, whether the number of people that might have increased opioid use and then overdosed was a consequence of stimulus cash spending. We just don't have the data. So I'm certainly just presenting that in terms of what our informants have said, not in terms of being a statistically significant finding. It might be possible to drill into that a little bit, but a lot of the available data is not at the individual level to protect protect patients. And so we are looking at generally population numbers or rates. It's also, the second thing is a little bit of a challenge to compare that time period, like just that 4 months with 2018. But I appreciate your comment about seeing that kind of that curve going down and then associating it with more positive employment numbers. And so I think the way that I would interpret 2018 is really in terms of beginning to see federal government agencies get more aggressive in terms of really surveilling some of these prescription opioids. And I think probably some of us on this call have experienced this, where we might have had surgery 10 years ago, and a script would just be offered for some pretty heavy duty medication. And then having gone through similar types of procedures more recently, it's a lot harder to get those kind of drugs. So I think that there's certainly been a change within the kind of pharmaceutical and medical establishment, which then to your second question is absolutely why when we look at, and that's why I wanted to show those waves. Our findings from the Journal of Drug Issues paper is that there was an increase in pharmaceutical opioids, but they were so negligible compared to some of the others that were being attributed to the overdoses that even one of the reviewers questioned whether we should mention it in the paper, but we still did because it was a finding. But the overwhelming surge was these illicit carfentanil, fentanyl. These are what's flooding the marketplace now. And that's, I think, a function of a number of factors, one of which is that there's been that pullback on prescription of opioids and, people shifting maybe to heroin and then potentially shifting to some of these other, kind of synthetic opioids. They're also much more addictive. And we also are hearing stories that some drug providers, I don't mean prescription drug, I mean people who are providing these drugs specifically might be lacing some of the drugs with like fentanyl, for example. And so we had an interview from in Kentucky, and there was a real spike in overdoses within like a week period. And this is when people on the ground really get aggressive and start asking people that come in for needles, for example, what's going on, where are these drugs potentially coming from, and then trying to warn them that there's a batch that could be potentially even more hazardous if used. And so to your second question, this is really regardless of whether or not there's a fourth wave, as I alluded to, we're going to continue to see that curve on those synthetic opioids really driving the epidemic. We're also hearing meth and some other drugs are also factoring in. And people are using alcohol, they're using multiple substances in some cases. So thank you for those questions.
So I assume based on some of the questions that still are out there, you would envision continuing this research. Can you share some of your ideas about what comes next?
Yeah, so our focus up until now has been primarily Pennsylvania because, again, the availability of those data through the ODI database. I should indicate that's an imperfect database, as all databases are. Thankfully, our colleague Louisa Holmes, I noticed that there were some cases of repeated, more than one reports of the same incident. And so there's some data scrubbing that we had to do to make that data set viable, which we did. The other issue in terms of being able to really conclusively say whether somebody had overdosed due to a specific substance is the only way you would know that is if you blood tested. And so in a lot of cases, what the database is doing is it's speculating what the opioid that caused the overdose. And so and that's contributing to the multiple cases as there's an overdose incident, and then they might list 2 or 3 different drugs. And so, so as a result, we had a procedure whereby we were actually analyzing those data. So to answer the question moving forward, we are committed to a multi-state analysis. And so the research design that we're pursuing is across Appalachia, but specifically looking at West Virginia, Kentucky, and Pennsylvania to try to understand state level variations. And we're also looking at the counties, and then we have a subset of counties to provide more of this kind of place-specific detail that I've tried to integrate in my presentation. I think the short answer is that we need to wait for the availability of some data sets that won't become available for another year or two to look at these similar kind of patterns. There's going to be a lag in the availability. Thankfully, Penn State University has a specific approved federal site to analyze census level data. And so as part of a proposal that we put in the National Science Foundation, we've asked for support for the purchasing and use of those data. So a lot of what we're going to be doing is expanding the geographic scope, and then also being able to go in much more detail, more rigorous detail with greater availability of data. So that's how I'd answer the question. But yes, I tend to focus on a smaller number of research projects and try to focus on them, with some degree of detail rather than juggle a variety of different projects. So this is really what I see myself working on closely for the next series of years.
Okay, thank you. Well, we've reached the end of the questions, and we've just about reached the end of the time for the presentation.
I think there's one question in the Q&A from Van Bowersock. Do you mind if I answer that quickly?
Oh, go ahead.
Yeah, Van, thank you. I saw you had a couple of comments and questions, and I appreciate your thanks. So thank you for being here today. So Van asked, what are the principal drivers of opioid use? Mental health, available cash, availability of illicit drugs, doctors overprescribing these drugs, others. The answer is yes. To all of those. It's some confluence of them. Overprescription of drugs is really now moving out of the picture. It's still a factor. People can still kind of overuse opioids. But when we think about kind of the main drivers, it is these other classes of opioids. And when we say they're all opioids, what this means is they have the same effect in the brain. They actually kind of fire the nerve centers in dealing with pain. And so the first wave of prescription opioids were being given to people, following surgeries. If there was, people were dealing with chronic pain, physical pain, there has been a lot of interest in, and part of the reason why we've seen a concentration initially within rural areas of Appalachia is it's associated with certain industries like the mining industry, where people are maybe more likely to potentially to get injured. These are also rural counties is where some of the clinics were really aggressively targeted, and where some of these pill mills were created. And this is what I'm saying, a pill mill. These are these scripts that were just being created and then sold. And so you had a black market on prescription drugs. That's been pulled back on. And so I think when we think about opioid use and misuse now, particularly during COVID, it is these other factors that you allude to. I mean, we always hear mental health as we're interviewing providers. Maybe the available cash, although we've talked about that a little bit just now, but then also, availability, economic stress, economic pressures. There are some studies that suggest that housing is a critically important factor for people in managing addiction. It provides structure, obviously provides some degree of peace in mind. And so in the Journal of Drug Issues paper, when we published it, we actually referenced a couple of papers from the Midwest that were warning that the housing impacts on housing due to COVID-19 could really drive this uptick in overdoses. And so there's just a variety of factors that interrelate at the individual level, at the family level, community level. And this is why I would argue is kind of geographic perspectives that I've been trying to share with you all today are so invaluable in trying to unpack the complexity and uncertainty about how opioid use and misuse might be imbricated by other factors, economic factors, as well as the pandemic itself. And Van shares, I'm sorry to hear that. Yeah, this issue of people getting injured, a lot of the prescriptions as well. There's a heartbreaking, New York Times has done some important reporting on this. There was a piece about 9 months ago, I think that was set in Pennsylvania, if I'm remembering correctly, or at least had case studies from Pennsylvania. And it was people getting addicted in high school and could get access to these, maybe illegally, or maybe were injured and were prescribed. And then basically, these were very addictive drugs, although there was just, a decade or more of the pharmaceutical industry saying they were not addictive at all. And this is why these lawsuits that you see in the media are now coming to a close, is because there's evidence that they were vastly understating or completely misstating the addictive qualities. And so this could then lead to other types of opioids and hence overdose. And so I'm very sorry to hear about your relative. And we know this is something that is part of the epidemic.
Brian, we did have one question that came in through chat,
Okay.
which I think would be interesting to answer. Who is the labor force creating the increased synthetic drugs? Where are they getting their raw materials, especially in light of the issues related to supply chain and difficulty getting commodity products? Yeah,
thank you, Annie, for that. And thanks for being here for the talk. It's great to see your name. I don't have complete understanding of the drug supply chains. What I have heard from interviews is that in terms of the geography of it, first and foremost, within these kind of, particularly some of the rural areas in Appalachia where we're focusing some of our work, they are coming from outside. And some of that could be, kind of deflecting. But our sense is that I've heard more than one informant say there's two key highway. 95 is one, another one coming out from Michigan, for example, that are part of the supply route for these drugs. I think that there's enough evidence. I want to be careful with this to not, be, kind of critical of another country, but production of fentanyl is coming from foreign markets, including in some cases from China. And so there is a global supply chain and production around some of the illicit opioids such as fentanyl. In terms of the raw materials and that go into their production, I would need to do more work, and I appreciate that question. It warrants some investigation. That's not something that I have as much understanding of. But thinking of, again, your question, if I'm taking it correctly, is a good reminder of the benefits of thinking about flows of movement, flows of capital, flows of drugs across state borders, across national borders, and how those can then result in very localized, place-specific impacts and variations. And I'm mindful of time, and this gives me the opportunity to conclude as a proud geographer. These are questions that geographers ask really well. And so all the more reason that I look forward to research from my collaborators, but also others to continue to shed some important light on the US opioid epidemic as we continue to move forward in this somewhat new normal.
Okay, thank you, Brian. I think we are out of questions now. I'd like to thank you again for agreeing to present today. I think it was a fascinating presentation, and questions certainly drew out some more information that was very helpful. So thanks again for agreeing to participate in this series, and thank you to the attendees for your questions and attendance. If you recall, please send any questions or suggestions for future presentations to ems.psu.edu. We really appreciate your feedback, and we'll look for some good ideas for future presentations. So thanks again for attending. Have a great rest of the day, and all stay safe. So long.
Thanks all.